chapter, and it slowed down for people joining us, so we'll go ahead and get started. Good morning and welcome everyone to the Spokane Regional Crisis Collaborative meeting. I'm Kalen Roy with the Spokane County Regional Behavioral Health ASO, and I'll be facilitating the meeting today. For anyone that is new to this meeting, just wanted to give a quick overview of the purpose of the SRCC. This meeting is held on a quarterly basis and allows for local stakeholders, community members, treatment providers, managed care organizations, law enforcement, tribes, and other emergency services to come together and discuss all topics related to our behavioral health crisis system, which covers our 6-county region, Spokane, Adams, Pend Oreille, Stevens, Ferry, and Lincoln counties. And it also provides the opportunity to share information on newer programs, identify any challenges, trends, and develop solutions for common goals throughout our region. For today's attendance, I'm going to ask that everyone please put your name, title, and agency in the chat so we can keep track of who is in attendance today. And with that, we'll get started with our first agenda item. We've got a few guest speakers today. So I'd like to introduce Lindsay Galvin-White with Frontier Behavioral Health to share about their MRSS program. So Lindsay, I will turn it over to you.
Hello there, hope you can hear me. Yeah, so I was told that you wanted us to come speak to you about our MRSS program. So really it's a mobile response stabilization service. That's what MRSS stands for. It is a program that we have here at Frontier. We've had in place for about a year. We've been seeing clients for about 9 months. This program works in tandem with our crisis arm of our youth mobile response program, which is CYF, Children, Youth, and Families Mobile Crisis. And together they're based off of the evidence-based practice designed through UConn called MRSS, which has a crisis intervention arm in a mobile response and a crisis stabilization arm in mobile response. So we receive referrals for youth not yet 21, so all the way up to age 20 and 364 days. Our goal is to respond as quick as possible in person to meet that person, client, youth, and or their family member, and to assess for their crisis. We do allow our families and clients to define what their crisis is. So some of our referrals are high risk, including suicidal ideation, homicidal ideation. A large amount of them fall into kind of a grave disability category where you have people that are not functioning at their developmental level because of a numerous amount of things. This could be not yet diagnosed autism, behavioral issues, parent-child difficulties, or symptoms due to mental health and some trauma that's been experience. So our goal is to go out and to assess them and provide them resources. And once we get them stable, we'll move that into our MRSS arm, which provides that stabilization for 6 to 8 weeks in home at that client's designated environment. So if they feel safest at home, we'll outreach there. If they'd rather meet us at a park or a library, we'll go there. And that 6 to 8 window we found is just really great to really get the client into the services that they initially identify as being important to them when their crisis is occurring. But so often what happens is after a day or two and the crisis kind of fizzles out, then it can be hard to want to or engage in that reconnection or connection to services like counseling or intensive outpatient treatment or med management, things that seemed very important at the time. And so with that 6 to 8 week window, we can really develop good rapport and engagement with these clients, have this client-centered care plan where they're designing what it is that they want to see happen. I want to have a better relationship with my parents. And in doing so, yeah, I did think that counseling would be pretty important. So yeah, I think I will call that appointment next week or book that appointment next week, etc. Um, so those are our youth mobile response programs. Um, Most of our referrals come to us through 988 or the regional crisis line. Um, we have about 20 staff. Most of them partner either two clinicians or a clinician and a peer. Sometimes it's appropriate for a peer to go out on their own or in tandem with another peer, depending on the needs of that particular client and their family system. Um, We feel like it's been a really great model to what's already been existing in terms of really minimizing hospitalization for youth and children, really paying attention to those least restrictive opportunities that are available to get care and mental health counseling, um, outside of extreme hospitalization. In the event that our clients do need some level of hospitalization and they're voluntary for that, we do help them facilitate that as well. I think that's most of my spiel about the programs that we're offering. I'm wondering if there was some specific questions or something that you guys would like me to cover that I did not.
Thank you, Lindsay. Any questions for her regarding the MRSS program?
I do have a question for you, Lindsay. So you said you get referrals from 988 and then regional crisis line. Is this like just any young person who is in crisis can call, or is it like they have to have a pre-established relationship with you guys?
Yeah, great question. So, like I said, 99% of our referrals are coming straight from our regional crisis line. So that's just based off of that 988 model, a safe place person to call. If it gets to the point where they need the safe person to outreach, that would be this MRSS CYF team. And then that third arm, that safe place to be, which is sometimes home, which is sometimes a hospital. So they don't previously have to be open with us. We just have to kind of have a crisis that they identify, and either they themselves, the client themselves calling, or someone on their behalf calling into our regional crisis line or 988 facilitates that.
Any other questions for Lindsay? Quick question, Lindsay. As far as MRSS program, is that also up and running in other regions around the state? And then are there any insurance restrictions or eligibility requirements?
I do believe there's other areas of the state. Some of our members here on this meeting might be better suited to explain that. I think Jessica maybe. Um, For us at FBH, we get our referral and we're going. We're not asking for insurance. We're just going and we're knocking and we're seeing how we can help. We will work with whatever insurance that they have available to try to connect them to the services that work for them. That includes, also looking for things, um, cash pay or off insurance or connecting them to insurance, things like that. Jessica, did you want to jump in that?
Yeah, thank you, Lindsay. To the question, Kaylin, related to if there's other MRSS programs throughout the state, I believe it's in Pierce County. They have an MRSS program that operates similar to how ours is. And I think as we move forward, MRSS and the stabilization services will become more integrated within the crisis system as a whole. So yes, and more to come.
Excellent. Sounds like a great resource for youth and families. So any other last questions for Lindsay? We appreciate you being here today and sharing about that.
I'll just say that we have a really great group of providers. They really love working with youth and their families and their support systems. And so very much looking forward to continuing to do our work and receiving your referrals.
Awesome. Thank you,
Thank you.
Lindsay. And for our next agenda item, we have Josh Henderson, Child and Adolescent Program Administrator here at the BHASO, to share about some clip updates. So Josh, I will turn it over to you.
Sounds good. Thank you. Good morning, everybody. I believe, Arlie, are you going to share the presentation? I think. Fantastic. Thanks, Arlia. Perfect. Yeah, and Arlie, I'll just let you know when to scroll down. That works for me. I hope that works for everyone else. Well, first and foremost, thank you, everyone. As Kaylin said, I am Josh Henderson with Spokane County BHASO. I get to work on a variety of our youth-based programs here, and one of those being the voluntary CLIP task force process. So here at these meetings, we usually try to provide just general updates on CLIP for the community, as well as a reminder of our task force committee process. The task force serves only voluntary referrals to CLIP. So if you're have questions about the involuntary process, happy to answer those questions as well. But the task force is specific to anyone either under 13, it'd be the legal guardian pursuing CLIP on a voluntary basis, or if a youth is 13 or over, the youth is agreeing to the CLIP process. So just a reminder for that when we're talking about task force here, that's only the voluntary side of CLIP referrals. And in general, just an update on CLIP wait times. I know that can fluctuate quite a bit. At this point, programs are a little bit more full. As a reminder, there's 4 CLIP programs in the state of Washington. CLIP stands for Children's Long-Term Inpatient Program. It's the highest level of inpatient care for youth in the state of Washington. There's Tamarack Center here in Spokane. That's the only CLIP facility here in our region. There's Two Rivers in Yakima. There's Pearl Youth Residence on the west side, and Child Study and Treatment Center as well on the west side. So there's 4 programs. At this point, there's about a 60 to 90 day wait list into those programs. And that's just when your name lands on the CLIP wait list. So I can provide more information on that. But that's both on the involuntary and voluntary side would be a 60 to 90 day wait list on that. So that's the kind of current CLIP updates as far as wait times go. They are working on expanding kind of beds and looking at capacity and working on that, which they have already. But of course, there is an influx in referrals at this point in time. I think overall there's 20 youth on the wait list for CLIP across the 4 programs. So that's throughout the state. So CLIP serves statewide level. So just as a reminder, it's not just local to our region. And our task force process serves a 6-county region. As Kaylin mentioned here, we have Spokane, Stevens, Ferry, Lincoln, Pend Oreille, and Adams counties are the counties of the Spokane Regional Service Area that our task force serves. And our Children's Intensive Resources Task Force, which I think there's folks on here today that participate in that committee. So this will be familiar information to you all, but really serves 2 functions. One, to just be a resource navigation for families looking at higher levels of inpatient care, and maybe they're not quite ready for CLIP, but really wanting to look at additional services that could be helpful. So we serve that function. I would say 99% of our referrals that we get are for the second option. So that's for youth or families wanting to look at CLIP as a resource. And so they felt like they've exhausted local community resources. And so they're really wanting to come to determine if CLIP is appropriate. And the task force is the voluntary referral mechanism arm for CLIP. And so to go to CLIP on a voluntary basis, you have to go through our task force committee process. That's a requirement from the state and the CLIP administration who oversees the CLIP programs. So if you lived in a different region of the state, you would have a similar process that you go through as well too. So this is a statewide process with unique differences for each region, but it's all pretty similar because they try to streamline things for families across the state. You can scroll down, Arlia. And so our committee composition is made up of a variety of system experts, so youth behavioral health experts. We have the chief psychologist from Frontier, Dr. Cordovan serves on that panel. Dr. Phelps Chang, the best psychiatrist from Sacred Heart. I think Holy Family now, I think they moved over there. And then a variety of other partners. So DCYF, DDA, Spokane Public Schools. we really try to have a robust committee that has expertise in youth behavioral health services to staff those cases. We want individuals to be able to know of community resources and things families may be eligible for, because even if we are recommending CLIP for a family, as I mentioned previously, there's a decent wait list. So we do try to come up to the best of our abilities, resources that could be helpful, even in the meantime, if CLIP is being recommended to help serve youth and families. So that's great that Lindsay spoke about MRSS. That's something that we've referred to as a recommendation, just so families are aware of that service, since it's a relatively new expansion of the crisis system of care. We want individuals to be aware that they can access that 24/7. All right, you can scroll down. So what is CLIP? I mentioned this already, a little bit of just what the CLIP program is. So families that really are looking at CLIP are kind of feeling like they've exhausted local community resources. And so we as a task force are privileged to be able to help those families look at what other options might be
Hey,
available.
Dave, this is Tamara calling from Sacred Heart Medical Center DCT program.
um, we're privileged to be able to help families who are really looking at that additional help. These are youth and families that feel like they have really exhausted everything and are really not sure where to go. So CLIP does serve that unique population of individuals needing a higher level of inpatient care. And so the average stay for CLIP is 9 months, which is a long time. That's across voluntary, involuntary. Families are a crucial part of that process. Those are questions that I work closely with our managed care partners on the front end of just providing education to families. So a lot of education is provided up front. When families are looking at CLIP, they've probably already done some research on what it is, but it's really helpful when we can share that up front so they really know what they're looking at. It's also helpful for youth as well. I think many times youth will think of an inpatient setting, maybe more like a community mental health setting, which looks much more different than a CLIP inpatient stay. CLIPadministration.org is the CLIP website. And so you can tour those facilities. I think there's even little videos on there as well that are unique to each program. But it's much different than a community hospital stay. They're geared for longer-term treatment. They have contracts with local school districts, so they partner with schools over there to provide education, recreational therapy, family therapy, group therapy, psychological and psychiatric services. I mean, they really provide a robust set of treatment services because they're serving youth for such a long period of time. And then who can access the task force? Anybody within our regional service area. And I've fielded many calls from family individual. So again, this is a statewide process. So if you know of anyone that might benefit and doesn't live in our region, feel free to let me know. I can definitely connect them as well to who that point of contact would be. But again, it's for youth under 13, it'd be their legal guardian wanting to pursue this as an option. And for youth over 13, they would need to agree to the process, which is really important because CLIP is an extensive process to get into that. And so I know families for youth maybe who are over 13 who aren't really sure about that. There's a lot of time and effort that goes into that on the family side of things, of just getting information and preparing that. And if the youth does not want to go, even if we make the recommendation, there's nothing that we can do to continue that process moving forward ultimately. So we really do have those conversations up front. It's also part of the CLIP application that the youth signs that document agreeing to that process too. So again, these are conversations that the managed care partners and myself are having. So everyone is on board on what the expectations are, knowing what they're agreeing to, what the purpose of the task force is, so family and youth can come prepared. And then what criteria to refer? Again, these are youth with complex behavioral health needs, looking at higher levels of inpatient care. That's kind of that first referral process. And then the second one would be youth and families who have exhausted local community resources and are really interested in looking at a higher level of care. So these are youth who maybe have exhausted day treatment programs, partial hospitalization programs. Maybe there's many referrals we get for youth that have engaged in WISE 2-3 times. And are just really struggling and needing additional resources. So these are the youth that we usually get referred to. Again, we have another program internal to our agency, the REACH program, that maybe serves youth that aren't quite ready for a task force level of care that does still do resource navigation. But again, our task force is going to be serving youth with really higher level of needs, looking at a higher level of inpatient care. And then the referral process is pretty straightforward. I would say 99% of the referrals we get are youth enrolled with a managed care entity. So I work really closely with their CLIP liaisons. Each MCO has a identified CLIP liaison that helps their youth. So if I get a referral first, it's my job to ensure that that information gets to the MCO so they can review it. All of the MCOs in our regions, CLIP liaisons serve on our task force committee, which is super helpful. But I work really closely with them to make sure that families feel supported, because again, the managed care entity is going to be the one that's providing the support, coverage for services. My role is to facilitate the meeting, make sure the individuals get all the calendar invites, the information. Of course, if it's a non-Medicaid youth or a youth with fee-for-service Medicaid, I would be responsible for covering that entire process for the youth. But if they have an MCO, that process is really closely linked with them, and I would be working with that entity as well. So if individuals here today are interested in what documents are needed, happy to send those out. Feel free to reach out to me. But we have a release of information, an intensive behavioral health screening form, which is a pretty straightforward document just for families and providers to fill out so our committee knows some of the kind of general basic information of what is the presenting concerns of the youth, and then any additional information to support the referral. So a requirement for the CLIP application is a psychiatric assessment that's completed within the last 6 months. Sometimes that can be confusing because either providers or family might think a psychological assessment, and it's actually a psychiatric assessment. So a psychiatrist or a psych ARNP would be the one that would complete that assessment within the last 6 months. So documents like that, hospital admission, discharge records, things that are going to help our committee better understand the conceptualization of the youth and the concern so we can best make appropriate recommendations. And we hold these meetings on Tuesdays via Zoom from 11 to 12:30. We don't have one every Tuesday, but when we do, that's when we do have them. I'm very thankful that we have such a robust committee that attends frequently. I think if we moved around the date all the time, we wouldn't have that. So that's one of the reasons we kind of hold that spot. So our committee members will know whether we're having one or not. And then, of course, I'm communicating with the families on scheduling those times. And just an additional maybe point on that last slide too is ultimately it's whoever the assigned CLIP liaison is going to sign off on moving forward with the task force. There are times that and it is rare, but there are times that I get a referral, and if it is a managed care entity, I'll send that referral over. We'll talk about it. There are times where maybe a family isn't aware of other resources that need to be exhausted first, because the CLIP administration does require that. I know I've mentioned that multiple times, but they really do look at that. And we wouldn't be doing a service to the family if we're recommending for CLIP and other resources haven't been tried, because ultimately the CLIP certification team is still the final sayer on entry into their program. I think over 95% of the time we say yes, they don't have any issues with that, but it is still their ultimate decision on that end. So we really try to make sure that we're following those guidelines from the CLIP administration. So we're not recommending families that are going to be then denied on the back end. And then what can youth and families expect? Again, I've noted this a couple times, but really a lot of these conversations happen on the front end. When I'm getting a referral for a youth, I'm working closely with the MCO, or if it's a youth signed to the ASO, then I'm working with the youth and family, but we're really trying to prepare them for the meeting. I don't want families to come prepared not really knowing what to expect. Of course, on some level, if they haven't gone through that, that might be what they're feeling, but I think as much information we can provide is upfront. It's helpful to know what they can expect. So I'm having those conversations with the youth, the family, like the flow of the meeting, what information would be helpful to share. Obviously, we're coming from a trauma-informed perspective, knowing that families are being very vulnerable with sharing kind of really the most sensitive details of their life with us. And so we really try to take a collaborative approach as a committee. Our goal is to help youth and families get connected to resources. And if that's CLIP, great. We want to do that, but we're really trying to support the family every step of the way, from the time we get the referral, the meeting, aftercare follow-up, checking in, seeing how things are going, and then obviously helping them follow through with any sort of recommendations that come forth from that. And I think that's probably the next slide here. Perfect. So from our committee, after each meeting, the family is going to get list of task force recommendations and a certified letter from either the MCO, CLIP liaison, or myself, if it's youth assigned to us, detailing what the committee recommended. And of course, CLIP would be addressed on there as well. But this is going to be a helpful document because whoever the assigned CLIP liaison is will help the family follow up with those recommendations. There's a lot of information shared during those meetings. And of course, there's a lot of high emotions and anxiety. We obviously don't want just families to, or we don't want to expect families just to remember everything that was talked about in there. We want to obviously make those recommendations, have an organized process of what those were, and then help follow up with the families if they have questions on how to connect with those resources as well. And so if a youth is recommended for CLIP after our meeting, and they'll know by the end of the meeting, we do a formal voting process in our task force. And that's just a simple majority voting process. If the majority of committee members think CLIP's appropriate, then that's the route that we go. And then whoever the assigned CLIP liaison is. So I facilitate all the task force meetings, but then if it's a youth with an MCO, after that, that MCO CLIP liaison will be helping the youth and family complete the CLIP application and all the necessary documentation to send that off to CLIP. And then CLIP reviews that, has their certification team look at it. And once the youth is certified, at that point, the youth goes on the wait list. So we really try to be clear with families too, that just because we say yes, at that point doesn't mean that the youth is on the wait list. So again, these are conversations that we are having in depth. And so that can take some time, but CLIP is pretty good about doing that, usually within a week or so of getting all the documentation of making a determination. Families do need to complete that information within 90 days of our meeting. And really the point of that is, if it's been longer than that, then CLIP is asking, does the youth even still need this level of care? That's really the purpose of putting that time frame on there. And so again, it shouldn't take 90 days. By no means. I always try to share that with families too. When they think 90 days, I think they're thinking, oh my goodness, there's going to be so much information. This is going to take forever. And there is some information that needs to be gathered, but there'll be a point person to help them throughout that process. And then if CLIP is not recommended, so at that process, again, if we're not recommending CLIP as a committee, the purpose of not recommending that is because we feel that other appropriate resources would meet the level of needs for the youth. But again, if families or the youth disagree with that and they want to pursue CLIP, they can appeal that decision, and that would be made to the CLIP administration with the help of the CLIP liaison. And at that point, really the family would be moving forward as if they were recommended for CLIP, but the letter from our committee that would accompany the documentation to the CLIP administration would say that, you know, we did not recommend, and the family's appealing that. So again, these are all helpful information to have families be aware of that on the front end. Because obviously if a family is looking at that and they're not recommended for that, that can be a really tough decision. It's hard for families, but if they have the information up front of what their options are, then of course they're more prepared to advocate for their needs and their child's needs as well. I think I'm trying to be mindful of time here. I think I touched on everything there. I want to make sure I leave time for questions. So this can you go up one more, Arlia, on the numbers there? Perfect. So over the course of last year, so we go from July 1st to June 30th. So these numbers here for state fiscal year 24 for July 1st, 2023 through June 30th of 2024, we received 25 referrals to our committee, 21 meetings convened. That differentiation there of the 4 is some of those examples I mentioned before, or maybe families have heard about CLIP and they think it's a great option, but really aren't aware of some of the other resources that would be more appropriate. So those are conversations that we have, and vast majority of the time, those families are like, oh yeah, we didn't know that existed. Great, yeah, we can pursue that and have someone help follow up with it on that end. But that's really some of those. Others can be the referral is made, family thinks about it, they want to pursue other options. But again, as you can tell, the vast majority of the referrals we get end up meeting the level of at least holding a task force meeting. And then of the 21, 13 were recommended for CLIP level of care. And so those other 8 are going to be youth that we thought other resources would be more appropriate. And again, those are going to be outlined in the recommendation letter from families. Each of those families have the ability to appeal the decision. But that is the breakdown from the numbers last year. And they're fairly consistent over the past 2 or 3 years. I would say this year was a little bit more of referrals that we got overall. And then recently, just the beginning of this fiscal year, so within the month of August and going into early September, we received a lot of referrals. And I think that could be due to the end of summer, school starting. So youth kind of becoming on the radar more, maybe having behavioral health concerns, or maybe we're doing better over the summer. There's a lot of different factors that go into that, but it was definitely a really busy time recently with referrals. I think we had probably 5 meetings in a row of task force referrals, families looking at CLIP recently. So, and I would say that's a little bit out of the ordinary. Again, we don't have them every week, but definitely saw an influx there, which would obviously coincide with the numbers from the CLIP administration as well, that they seem to be getting additional referrals at this time. Perfect. I think I capped it right about 15 minutes here. I want to obviously make sure I can answer any questions that you all have, because CLIP is a complex process. There's a lot of moving parts. There's a lot of individuals involved in the process. So I want to make sure that I can answer any questions that folks have on either CLIP or just our task force process and how we make referrals and do that whole thing.
Do we have any questions for Josh? I'm not seeing any in the chat.
I was just going to say, excellent presentation, Josh. It's Christine with Community Health Plan of Washington.
Hi, Christine.
Hi, yeah.
Thank you.
Yes, we appreciate the detailed overview and all the information. If anyone is joining us a little bit late, please remember to put your name, title, and organization in the chat.
And my contact information is in the slide presentation as well. So if you do have questions, feel more comfortable reaching out to me that way, please do so. Happy to be a resource.
Excellent. Thank you, Josh.
Yes, thank you.
So back to our next agenda item. So we have Max Kaufman and Susan Straka. Hopefully I'm pronouncing that correctly, to share about some of the exciting things that they're doing with the Team Child program. So Susan, I see you. I will turn it over to you.
And I will just say that Max was actually unable to join us this morning, but I got us covered.
Susan, we're having a tough time hearing. I can hear you, but you're a little bit quiet.
What's better? Give me 1 second. I changed my audio. Is this any different?
Way better. Way better. Thank you.
Wonderful. Okay. I'm also realizing that I put my information in the chat, but it was accidentally a direct message to the AI platform doing the transcribing. But hello, everyone. My name is Susan Straka. I am the staff attorney at our Spokane Team Child office. And I'm just going to share with you guys a little bit about what we do, since we're all in the field of working to help young people. Let me share my screen for you. All right, are we all seeing this okay?
Not seeing anything quite yet.
Noted. Okay. Did that change anything? Probably not.
No.
Okay, sorry about this.
Wait, now something, there we go. Now it is showing.
Now we're there? Okay, great. Okay. So this is just kind of our, also, sorry, my webcam's off, so it's gonna look like I'm not looking at you guys. But this is just kind of our general presentation that we give to different community members. So it's just a broad overview. And I think I can hopefully maybe tie it into the behavioral health, mental health realm as well. So this is just a photo of our team. We've got a really great group of people. So just to get us started,
our role at Team Child, we are in the business of upholding the rights of youth involved or being involved in the juvenile legal system to help them secure education, healthcare, housing, and other support needed to achieve positive outcomes in their lives. And that looks a lot of different ways kind of in the legal realm as far as like what legal services we are able to offer those young people. Also, Team Child is an abolitionist organization. We're working to eliminate juvenile incarceration because we're aware that it is a system of harm that is much less rehabilitative than I think we would all hope for that to be. This is just a bit about our vision, kind of ties into just what I was speaking about. But it's really premised on just the simple fact that young people have the power and experience to experience unconditional belonging at school, home, and in their communities. Anti-racism is a big part of the work we do. So in all of our work, we are making sure that that is at the forefront. Additionally, when we are working with young people, those young people are our clients, even though we might be working with their parents in some capacity, depending on like the type of case that it might be. Obviously, sometimes parents would be adverse to what we are trying to assist the young person with. So there's a couple branches of Team Child. First off is our legal services. I am located right here in Spokane. I'm in the community building downtown. We are, however, a statewide organization, as well as we do work across the state with young people that are incarcerated at juvenile rehabilitation facilities. There's also a bit of training and consulting that we do as far as like know your rights trainings, and also just working with different community organizations. We are always game to be part of a brainstorm if something is seeming particularly complicated for a young person. And then we also have a policy team working in Olympia to do all of the cool things for young people in Washington. As far as the young people we serve, they're young people ages 12 to 24. We do have income cap at 200% of the federal poverty line. Of course, like if there is perhaps a situation where a family is right above that and, you know, there's extenuating circumstances, we'll still do our best to help them how we can, if not be able to refer them to a different community organization that could. We do prioritize young people with criminal juvenile court involvement. It's our objective to like extricate young people from those systems because once young people are involved, it's really hard to get out. The bulk of our legal services are concentrated in Spokane County, Yakima, Pierce County, and King County. However, like I said, we are statewide in that any young people currently in a JR facility, we would help them. I mean, that looks a lot of different ways, but a lot of times in those facilities, it's with civil rights complaints or the policy work to try and improve those facilities. Just kind of an example of like the flexibility of kind of the young people we work with. I started working with a young person in Spokane. They found their way up to Job Corps in Ferry County. So I've made a couple 3-hour trips up there. I think we're like largely willing to do the work to help these young people. This is just like a broad overview of our legal services. We touch on a couple different areas of the law, with education, school discipline, anything involving like a school perhaps not honoring an IEP or 504 plan. Enrollment as far as that's a large part for young people that might not be housed with a parent or legal guardian. Housing stability is another big piece of what we do. We have a senior housing attorney that's specifically working with young people. And that can look a lot of different ways. Relevant, I think, to this group is hospital boarding that happens. If, you know, say a hospital discharges a young person, but then the parents won't agree to pick them up, or the same thing happens if the young person is incarcerated at like a county detention facility. So helping them navigate that situation. There's a bit of post-conviction work we do as well. So yeah, I like to think that if a young person comes to us with a legal problem, we'll help them navigate it. Even if we're not able to offer that active representation, we'll still try and help them make sense of the situation. As far as referrals go, anyone can request Team Child Services. These are our different referral methods. And also directly on our website is a Get Help Now button, which will take you directly to our referral site too. As far as like emergency services, we don't consider ourselves to be emergency support, only because the legal system obviously takes some time to get things moving. However, it's certainly frequently the case that our clients will find themselves in crisis, and we'll try and help them navigate out of that. But for just like a person interacting with us for the first time, we do have a referral process. We'll need to get information as far as situation, income information, do a conflicts check, things like that. These are just resources. I'm happy to make this presentation available to everyone today in case you have any desire to click around these links. Washington, I think has a lot of available resources for self-help online. But also the people we're working with are young people, and the legal system is scary and confusing. And even though there are many guides to help, it's yeah, not an easy thing to do alone. And we are happy to be able to help them through that process. Another just kind of thing about Team Child is we do have a youth advisory board that works with our community engagement team in identifying different policy measures we might want to take, and identifying patterns that they've noticed as young people with lived experience, typically within different systems, be it juvenile foster care, as well as people that are young people that have spent time in mental health facilities as well. Our youth advisory board, we actually kind of shared with a couple partner organizations for a couple of years, and post-COVID, to really address kind of the educational gaps that COVID created. However, that funding kind of shifted, and now this year we have our own dedicated Team Child Youth Advisory Board. So that's a very exciting thing that we're excited to be able to kind of shape into what we want it to look like. Questions, anyone? Oh, I think this might be the last slide, but I thought there was a slide about legal services that we do not assist with. And maybe I blazed past it. But for immigration matters, we would refer to a community partner if a young person came to us with immigration issue. Similarly, family law, even though so much of what we do kind of like toes the line of family law, We can't get involved if it's like a custody matter, if it's a parenting plan. So yeah, just some things to keep in mind, but we are here as a resource in the community. I'm here in Spokane. Obviously, I'm one person, and there is capacity to consider, but yeah, I think I'm just excited about getting Teen Child's name out there. We have been in Spokane for a while, and by a while, I mean like since the 90s. So just want to make sure people are aware that we exist as a resource, and I'm happy to answer any questions anyone has.
Any questions for Susan? I'm looking at the chat here. Not seeing any. Not hearing any. Well, if you do have any questions for Susan, feel free to reach out to her. We appreciate you sharing about Teen Child.
Definitely, and I will drop my personal contact info in the chat as well.
Perfect. All right, so right on time, we're moving to our next item, which is kind of open for provider updates or any other walk-on agenda items that would be good for discussion. So I will turn it over to the group. Anything else that people want to discuss today? I will take 6-second silence as doesn't sound like there's anything pressing for the agenda. Just wanted to remind everyone that our next SRCC meeting will be in December, next quarter. If anybody has any one that they would like to add to this distribution list or think that would be good for them to be involved, please send us an email. And I want to thank all our presenters, Lindsay, Susan, and Josh, for joining us today, and hope everybody has a good rest of your week. Thanks, everyone.
Thanks, Galen.
Thanks, Jalen.